I am Himanshu from the Bayer Medical team. Firstly, I'd like to thank you all for taking out time from your busy schedules. And we are here for the Bayer Eyesight meetings, where we'll be having two talks. And the speaker for the first talk is Dr. Vinay Prasad from Sharp Sight Hospital. He has over 10 years of experience in management of diabetic retinopathy, vitrectomy, retinal detachment, and macular disorders. So Dr. Vinay will be speaking on aflibercept treat and extend long-lasting benefits and reduce treatment frequency in NAMD. The talk will be of around 20 minutes. And the second speaker for today is Dr. Sugandha Goyal from Center for Sight. She has over 10 years of experience, and she will be speaking on evaluating the need for change, evidence and insights on anti-VEGF therapies. Our panelists for today's talks are Dr. Sudhi, Dr. Angita, and Dr. S.K. Banwal. So, with that, I'll hand over the session to Dr. Vinay. Over to you, sir.
Good evening, everyone. Am I audible?
Yes, sir, we can hear you.
Yeah. So thank you, Bayer, for inviting me to this talk and allowing me to present. So I'll just share the screen. Is it seen now?
Yes, sir, we can see it.
Yeah. So today's my topic is aflibercept treat and extend. Uh, is this screen seen?
Yes, sir, we can see the screen, but I think slideshow is not on yet.
Slideshow. I want the slideshow actually.
Okay.
Now is it seen?
Anyone else can see that? Because I think for
Because
me,
I have seen I'm sharing it, but it is showing the screen sharing is paused.
okay. Yes, sir, we were also seeing that screen where you were trying to put the cursor on slideshow, but the screens were not on actually on slideshow. It was just the basic version.
Let me just go to. Now is it okay?
Yes, sir. Now we can see it.
Yeah. Yeah. So thank you everyone for joining here today evening for this talk organized by Bayer. Basically, we are talking about aflibercept treat and extend, long-lasting benefits and reduce treatment frequency. So as we all know, neovascular AMD is one of the most tedious things to treat, and basically the unresolved issues in this kind of conditions, they are basically divided into three groups. One of this is the patient factors, basically non-adherence or non-compliance, the cost of therapy, high individual treatment burden, and the poor prognosis. So all this act as a deterrent to the giving the patients the proper treatment. The second are the therapeutic factors, basically relatively short duration of action resulting in repeated treatment. So this is what we are basically focusing on today's slides here. And other thing is the poor efficacy resulting in persistent active disease and also the safety profile. Healthcare systems which cause an unmet need, they are high treatment burden to the society, reimbursement subsidies, and increasing the patient load. So here we can see that the need for reducing the treatment burden with current anti-VEGF agents for the patients is increasing day by day. And in a EURETINA clinical trend survey in 2022, 72% of the respondents have agreed that the quantity of injections is the largest unmet need with the current anti-VEGF treatments. So you can see that the trend raising from 2016 to 2022, it is increasing. And that is one of the major concerns. Coming to this slide where we can see there is a variation in VEGF suppression time between patients indicates a need for the treatment individualization. Always we need to give a individualized treatment to the patient because every patient will differ in how he responds at 1 month, 2 months, 3 months, and so on. So here we can see the mean duration of VEGF-A suppression by aflibercept is around 71 plus or minus 18 days. And the duration of VEGF suppression with aflibercept varies up to 16 weeks in patients with neovascular AMD. And the definitive VEGF suppression is around 8 weeks here. So coming to the how we can go on with this. So we implement a treat and extend regime in clinical practice. In the aflibercept treat and extend protocol, treatment is initiated with 1 injection per month for 3 consecutive doses. The treatment interval is then extended to 2 months. The patient receives an injection at every visit with no monitoring between visits, and the time between treatments is gradually extended until fluid recurs or the visual acuity declines in order to determine the maximum treatment interval with disease stability. And that is one of the unmet needs which we all are concerned about. So we treat more frequently if visual acuity and or the anatomic status is deteriorating. So we extend until the fluid recurs or the visual acuity declines. The decreased interval to a previous stable interval, and we maintain the patient at this interval, will minimize the treatment burden and fluid fluctuation. So the durability of current anti-VEGFs. So coming to ranibizumab, treat and extend basically requires a high burden of treatment, as we can see in this slide. Various studies have been done. In the third column, if you see the Lucas, the the number of injections and the treatment is less because they were started with patients with higher visual acuity. That is the reason they have given here. So overall, there is a trend which is around 30 to 40%, where there is a mean change in BCVA of around 6%, and the average injections range from 28-15 to 37%. So these are the gains which basically it increases the number of injections which you have to give to the patients. So coming to another study, the Hawk and Harrier, only 39 to 45% of patients were maintained on 12 weekly dosing with brolucizumab 6 milligram by week 96. So what we can see here is the number of patients which could be maintained with the number of with brolucizumab 6 milligram, though the number of injections is almost the same, but the amount of patients decreased. It is around 45 and 39 in both the studies. So despite the relatively high molar concentration, its relatively small molecular weight means that it has a shorter intraocular half-life. So it clears from the eye quickly. So only 39 to 45% could be maintained on every 12 weekly dosing by week 96 or by 2 years. So when administered at matched 8 weekly treatment intervals, faricimab 6 milligram may increase the treatment burden compared with aflibercept. So here in 2 studies, we could see that up to 25.8% of patients receiving faricimab could not be extended beyond the 8 week at year 2, because that was a limitation of the study. So does not reduce the treatment burden compared to treatment with aflibercept, but rather requires 1 additional exposure. So the initial loading dose is more. You have to give 4 injections for faricimab compared to 3 for aflibercept. Coming to the durability versus aflibercept, the study design TENAI and Lucerne, that is what I told. 1 additional loading dose was required. Secondly, more than 8 week intervals were not permitted with aflibercept. So that was the limitation of this study. So we are mandated to receive every 8 weekly dosing. Now coming to the main study, which was designed to assess the efficacy of 2 different aflibercept treat and extend regimes. So they were given at 2 weekly intervals in the initial week. The first 3 loading doses were given at 4 week interval adjustment. And then at 16th week, there was a randomization where in one group, the treatment visit according to the treat and extend dosing, every 2 weeks, they used to increase the duration. And if there is no change, and they used to reduce it by 2 weeks if from the last interval according to the criteria, if it is increasing, decreasing, or stable. And the other randomization was at 4 weeks or treatment visit according to the treat and extend dosing regimen. So these were the 2 things. So treat and extend interval adjustment criteria, they are basically 3: extend, maintain, shorten. So if you want to extend, there should be no fluid present. no loss of more than or equal to 5 ETDRS letters, no increase in CRT of more than 100, and no new neovascularization or no new macular hemorrhages. So if these are the 5 things which you are seeing, we can extend the treatment either by every 2 weeks or after the initial 3 or 5 loading doses. If you want to maintain the same interval as before, there should be any residual but decreased fluid, and the other all categories remain the same. And if we have to shorten the duration where you have to give more multiple injections, if new fluid is present and or there is a persistent unchanged or increased fluid, loss of more than 5 TDRS letters, increased CRT, neovascularization, which is new, or any new macular hemorrhages. So Altair included an option for patients to be maintained on their current injection level in the presence of residual but decreased fluid. So that was the important thing where we can still maintain them on this criteria, what they're controlling. So some pivotal RCTs support the efficacy and durability of aflibercept 2 milligram in patients with NMD. So basically, Altair was a multi-center randomized open label phase 4 study in treatment naive patients. So the mean change in BCVA from baseline and injections number at week 96 are given here. 2-week treat and extend, there was a gain of plus 7.6 letters on the ETDRS. In the 4-week extension, there was a gain of plus 6.1, and the number of injections were remained almost the same. And the proportion of patients, what we have to see is at 16 weekly intervals, at the final visit remained higher for the 4-week treat and extend rather than for the 2-week treat and extend. So by week 96, almost 56 to 56.9, almost 57 to 60% of patients were maintained at injections interval of 12 weeks and beyond. So that is very good. Last injection interval here, we can see there at 16 weeks, we could maintain it around 46.3% of the patients. And the mean last injection interval was between 12.2 to 12.5 weeks in the 2-week and the 4-week respectively. Here we can see that the patients extended to and maintained at 16 weekly was basically 46.3% for the 4-week adjustment and 41.5% that we have seen from the previous slides. So here we can see that the vision gains, the mean number of injections at week 52 in the 2-week group was at 7.2, in the 4-week group it was 6.9. And the mean number of injections through week 96 was around 10.4 for both the groups respectively. So can aflibercept achieve the RCT-like outcomes in clinical practice? Let us see in the coming slides where some real life settings were seen. So Jaggi et al, what they showed was that 35, they basically made a exit criteria where if on 3 occasions of 12 weeks, the patients have achieved at who are at 16-week intervals, and on 3 consecutive visits, they are stable. There is no residual fluid. They can exit the criteria and they can regularly have a 12-weekly control visits, allow timely identification of potential recurrence when the treatment should be resumed. In a study by Maruko et al, vision improved from baseline to year 2 with aflibercept treat and extend with up to 61% of patients achieving dosing intervals of 3 months. So this was almost comparable to the Altair study where they had number of injections over 1 year around 7 and over 2 years it was around 30. So by year 2, 60.8% of patients were being treated at an interval of 3 months. So we can note that the lower logMAR values basically indicate that the visual function is better than before. And in a study by Taipale et al, up to 67% of patients treated with a rapid extension protocol achieved dosing intervals of 3 months after 2 years. So here there was a criteria where there was a rapid treat and extend and a moderate treat and extend. So in the moderate treat and extend, basically the extension is done by 1 week at a time up to 12 weeks, and then by 2 weeks at a time up to 16 weeks. In the rapid, they extend directly to 8 weeks and then every 2 weeks up to 16 weeks. So that is the difference between the treat and extend moderate and the rapid. So at year 2, 46% and 67% of patients were being treated at an interval of 12 weeks and beyond in the treat and extend moderate and the treat and extend rapid groups respectively. So the study by Itagaki et al, up to 75.3% of eyes achieved dosing intervals of 3 months after 3 years of proactive treat and extend with aflibercept. So this is a 3-year study where 75% of 0.3% of the eyes could be extended to intervals of 3 months after the final aflibercept injection. So 2-year real, this is published in the Ophthalmology Therapy Journal. 2-year real world results for aflibercept using the treat and extend regimen in neovascular ARMD and PCV. So there's an improvement from 0.75 to 0.6 at 3 months after treatment initiation. It was done in a patient, or 43 total patients were taken enrolled, and further improved to 0.6 at 24 months. The number of injections within the 2-year treatment course was 10.95. At a 24-month of the treat and extend regime, the treatment interval was extended to more than 16 weeks in 60.5% of all cases and to 78.9% of the PCV cases. So the real world evidence supports the long-term effectiveness and durability of aflibercept with a proactive treat and extend regime. So in all the cases, we can see that almost more than 45 to 50% of the patients can achieve a 12 weekly at 2-year, at 4-year, and in a different study by Jaggi, 35% of the patients could exit the treatment after 3 years of the injections. A wealth of RV indicates that a proactive treatment even with aflibercept 2 milligram can provide RCT-like outcomes in routine clinical practice. So I feel this is very important for us all to note down this and put it in daily practice. Aflibercept 2 milligram has set a high bar for patient outcomes, as we have seen in the previous slides, with a proven efficacy in the clinic. Of all available anti-VEGF agents, aflibercept binds the most diverse range of VEGFR1 ligands, the key drivers of retinal disease. As supported by a wealth of data, aflibercept 2 milligram has been shown to deliver in cases of neovascular ARMD as well as PCV, improving the long-term outcomes with regular or proactive treatment. Basically, the best, I feel, the effect of the treat and extend is whenever the patient visits the clinic, he always comes for an injection. He doesn't come for a follow-up. So that also helps in minimizing the number of visits to the clinic as well as giving him outcome wherever he is coming and approaching us. Aflibercept treat and extend offers the flexibility to achieve and maintain vision gains with intervals of 4 weekly, 16 weekly, while tolerating some residual fluid and reducing the treatment burden. So these are a few cases where I have been using the treat and extend for this patient. This is a patient with having some chronic renal failure, and he was denied anti-VEGF injections everywhere. And then he approached us, and I injected and gave him the Eylea. At initial 3 dosings were given, and this is the final outcome at 8th month. Now he's still undergoing the treatment. He's still in the treat and extend. This is another patient who had come with a chronic CNVM, long-standing, but he had not taken any treatment. So he has undergone, this is the final outcome after 5 loading doses, where you can see that most of the edema and the NSR thickening is gone, but the residual subretinal fibrosis still persists. So this was after 5 consecutive injections. This is also another case of chronic case where the patient had approached to us at a very late stage. Still, he's undergoing treatment. He has almost undergone 3 consecutive injections, and we are awaiting for the final results. In this case, I would like to tell that there was some intraocular inflammation also after the 3rd injection of Eylea, which we had treated conservatively with stronger ocular steroids and anti-inflammatory agents. So, thank you everyone for talk.
Thank you very much, sir, for a wonderful talk. You covered almost the whole concept of treat and extend exhaustively. So I'll just ask the panelists that whether we'll take the questions right now or after Dr. Sugandha's talk. So do we have Dr. Sudhi, Dr. Ankita, or Dr. Banwal with us? Anyone? Okay, sir. Maybe Dr. Sugandha can continue with the talk, and meanwhile, after this, we can take the questions simultaneously for both the talks. Ma'am?
Should I start sharing my slide?
Yes.
First of all, Dr. Vinay has to, I think, exit the.
Okay, wait. I have exited.
Okay, exited. Okay, fine.
Exited,
Thanks.
exited.
Okay, fine. Are my slides visible?
Yes, yes.
Okay, just give me 1 second. So good evening, everyone. Today I'm going to talk about evaluating the need for change evidence and insights on anti-VEGF therapies. So the current management in neovascular age-related macular degeneration, there are multiple anti-VEGFs available in the market like bevacizumab, ranibizumab, aflibercept, brolucizumab, and faricimab. Although there is no cure, timely treatment can help achieve the neovascular AMD treatment goals of drying affected eyes by inhibiting new blood vessels that leak blood and fluid and help in improving or maintaining vision over a longer period of time. However, in real-world settings, there are significant gaps and challenges that pose barrier to achieving these goals. So the challenges that we face in wet AMD management using anti-VEGF, like there are significant inter-individual differences in response to an anti-VEGF agent. And there are multiple anti-VEGF agents available in the market with different molecular configurations. And the response to anti-VEGF therapy have been found to be dependent on variety of factors, like the age of the patient, the characteristics of the lesion, the duration of the lesion, the baseline visual acuity, and the presence of particular genotype risk alleles. So currently there is no consensus as how to classify the optimal response or lack of it with these therapies. So first of all, we should define the response to anti-VEGF. We say the primary response is seen 1 month following the last loading dose, and the secondary response is anytime after the 4th visit. And the secondary responses do not mirror and cannot be predicted from that in the primary phase. And there is a ceiling effect that can negate the currently used functional metrics, that is more than 5-letter improvement when the baseline visual acuity is good, that is when ETDR is more than 70 letters. So it is important to use a combination parameter to see the response to anti-VEGF. So the change in visual function we assess by visual acuity measurement at the baseline and then on the follow-up visits. And the morphology of the macula is accurately assessed with the help of OCT scan. ICG we usually do in cases if we suspect PCV or RAP, or if the patient is non-responsive to any anti-VEGF therapy. So we say the patient is having good response if there is absence of subretinal fluid, intraretinal cyst, or reduction of central retinal thickness more than 75% of the baseline values. And the functional response when there is improvement in visual acuity in more than 5 letters from the baseline. And the partial response when the reduction of central retinal thickness is between 25 to 75% from the baseline, and there is persistence of fluid or any appearance of the new fluid. And the functional if there is change in vision of 1 to 5 letters from the baseline. And we say the response is poor if there is between 0 to 25% reduction in central retinal thickness, and there is persistence of fluid or appearance of new fluid, and the change in vision of less than 4 letters. And we say there is no response if there is unchanging or increasing central retinal thickness, subretinal fluid, intraretinal fluid, or PED compared to the baseline. And there is less than 5-letter change, or if there is decline in visual acuity from the baseline from 1 month after the third injection. So switching to the newer anti-VEGF therapies, is there hope or a hype? So the real-world studies with faricimab in neovascular AMD have shown limited vision gains. So it has been seen that after 3 loading doses of faricimab injections in a study by Mukoi et al. In the treatment-naive patient had plus 4-letter vision gain. And the study by Trucchi et al. After switching the patient from aflibercept, there was 2.2-letter vision gain. And in the naive patient, there was plus 8.1. And a study by Murphy et al. In which there were 4 loading doses of faricimab injections given. When the patients were switched from aflibercept, there was reduction in the visual gain. And the far retina, when the patient was switched from alternative anti-VEGF, there was plus 0.3 letter in visual gain. And in the naive patient, there was only plus 3.7 letters visual gain. So it was seen that in the study by Kotoeka et al., in which the 130 eyes who were previously treated with aflibercept were switched to faricimab injection at 4-week intervals, followed by minimum Q8 intervals. So it was found that from the baseline to month 6, around 60% of the patient discontinued faricimab treatment, out of which 92% discontinued due to insufficient efficacy of faricimab, and the 73% switched back to aflibercept. It was also shown there was no change in visual acuity, there was minimal change in central retinal thickness, and majority of the patient could not be extended beyond Q8 interval. So in the study by Kishi et al., in which they did study in 55 eyes previously treated with aflibercept at less than Q8 interval, who were switched to faricimab with interval based on treat and extend regimen interval before switch. After 3 loading doses of faricimab injection, there was no change in visual acuity. Mixed outcomes were seen in anatomic parameters, and more than 70% of the patients who were switched from aflibercept to faricimab remained on less than Q8 intervals from the baseline. Also, in a study by Hara et al., it was seen that when 3 loading doses were given, there were significantly better visual outcomes observed in aflibercept group as compared to faricimab group, and there was mean central retinal thickness markedly improved from baseline to month 3 in both the groups. So 72.1% of the previously treated eyes were switched from aflibercept in a study by Bailey C. et al., in which they had shown that 6 months of real-world study in DME patients, there were limited visual gain. As seen in this graph, that after 4th injection also, there was 0.7 mean change in BCVA. The injection sequence also, there was limited improvement on intravitreal therapy intervals also. So in which the 86% of the patients who were switched from aflibercept, despite multiple injections of faricimab, majority of the patients were could not extend to more than Q8 intervals. So there have been several different approaches attempted in effort to improve outcomes in these patients. So could targeting additional pathways beyond the VEGF pathway be beneficial? So the different approaches which have been attempted are, so there was a study which was done earlier in which they combined aflibercept with nesvecumab. So nesvecumab acts on Ang2 protein, and aflibercept we all know acts on VEGF-A, VEGF-B, and the placental growth factor. It was found that there was no additional clinical benefit of adding nesvecumab. And another study like faricimab, we have already seen that there is non-inferior efficacy. And brolucizumab, which acts against VEGF-A, it has higher molar dose with small antibody fragment. And this ranibizumab port delivery system has limited use due to the manufacturing issues. So we'll discuss one by one. First of all, we'll discuss this combination of aflibercept with nesvecumab. So in a study by Ruby, on DME patients and Onyx trial in neovascular AMD patients, they combined intravitreal aflibercept 2 mg with nesvecumab, which is a potent Ang2 inhibitor. So it was seen that combination provided no additional functional benefits as compared to aflibercept monotherapy. And the other thing now, faricimab, which acts on Ang2 protein, in a study by Tinaya and Lucene, it was found that faricimab was non-inferior to aflibercept 2 mg for mean best-corrected visual acuity change. In a study by Avenue, they had shown that ranibizumab and faricimab achieved similar levels of plasma Ang2 inhibition after one injection. So in the graph, we can see that a single dose of intravitreal ranibizumab 0.5 mg reduced total Ang2 in human plasma to below lower limit of quantification that was found equipotent to a single dose of faricimab 6 mg. So this data suggests that if we give only anti-VEGF monotherapy, it neutralizes Ang2 to the levels that are comparable to that achieved when we target directly Ang2. So thus aligning the known biological activity of Ang2, whereby Ang2 is down-regulating by decreasing VEGF-A levels. So faricimab failed to meet the primary endpoint of superiority to ranibizumab for visual gain at week 36, and the level of Ang2 inhibition were similar between both the agents. So it suggests that anti-Ang2 mode of action of faricimab may provide no additional benefit over anti-VEGF monotherapy. So, the VEGF binding arm of faricimab is ranibizumab, and the role of Ang2 has not been established to show clinical effectiveness. And the FDA have stated that the VEGF antigen binding fragment is identical to ranibizumab, and the contribution of Ang2 inhibition to the treatment effect and clinical response for neovascular AMD and DME has yet to be established. So the preclinical data suggests that VEGF is a key driver of Ang2 production, and these anti-VEGF agents can block VEGF-R-driven Ang2 generation. Aflibercept has shown the most durable effect in blocking the effect of human VEGF on Ang2 levels in this preclinical rabbit model. So the result of this study support that hypothesis that Ang2 may be expressed secondary to primary insults to retinal vasculature by VEGF. So the direct inhibition of Ang2 may not be clinically relevant. So it is currently provided by the anti-VEGF treatment alone. So VEGFR pathway remains the master regulator in the retinal disease. We all know that the VEGF pathway is the master regulator of pathological angiogenesis. So whenever there is any pathological condition, it leads to increase in VEGF and placental growth factor levels due to hypoxia. So VEGF-A binds to VEGFR2, and VEGF-A and placental growth factors bind to VEGFRF. Their excess activation leads to inflammation, neovascularization, and retinal vascular leakage and edema. So we should know what is placental growth factor. So it is a member of VEGF family that is expressed by multiple cell types under pathological conditions. It binds to VEGFR1, and both VEGF-A and placental growth factor are the key components of the inflammatory response cascade. So aflibercept is the only widely approved agent that is blocking all the VEGFR1 ligands and the key VEGFR2 ligand also. So as we see in this diagram that other approved anti-VEGF agents like brolucizumab, faricimab and ranibizumab, despite the complete inhibition of VEGF-A, placental growth factor mediated effects can still be activated through VEGFR signaling. So this aflibercept targets VEGF, that is the master regulator of the disease pathology. Apart from that, it is also additionally targeting the key ligand, that is the placental growth factor. So coming to the summary, so with aflibercept 2 mg already targeting key ligands of the master regulator VEGF pathway, there may be limited potential for improvement in functional outcome for patients. So increasing the molar dose of anti-VEGF agent may have the potential to offer patients more through extended VEGF production. So have we maximized outcomes for our patients, or can we go further with disease control? So aflibercept 2 mg has set the bar high for treatment of exudative retinal disease, with novel agents yet to surpass its standard of care, vision gains, durability, and safety profile across indications. We have already discussed that aflibercept targets the key ligands of the VEGF pathway, hence the master regulator of pathological angiogenesis. So targeting other pathways has not resulted in improvement patient outcomes beyond aflibercept. So the data from PULSAR and PHOTON study has suggested that aflibercept 8 mg has the potential for greater and longer lasting control of the underlying disease compared with aflibercept 2 mg through the sustained disease control. Thank you for your patient listening.
Thank you very much, ma'am, for wonderfully covering all the points related to the pathophysiology, VEGF, Ang2. I know it can be a lot of data to consume and then present it in a very lucid manner, but you did it fantastically. Thanks, ma'am.
Thank you.
Sir, I think we don't have the panelist here, so I have a few questions for both of you, and if from the audience anyone wants to ask, they can just ask directly. So, sir, if we talk about treat and extend, although it's a concept which has been followed since a long time in Western countries, because price is not a factor there. If we talk about US, Europe, mostly it's reimbursable market. But India being a price sensitive market, sir, I am based in Delhi and I look after the whole North India. So I keep on visiting different centers. So here, in fact, in Delhi also, apart from 2 or 3 big centers, mostly the practice is PRN just because of the economics of the drug. So my question is, sir, that what percentage of your patients do you put on treat and extend, and how easy it or how difficult it is for you to explain them what treat and extend is?
See, what I do is basically I see from what background the patient is coming,
Yes, sir.
how long he has to travel to reach. Is there a permanent person who is going to accompany him? All these are the questions I first ask, because that gives me clarity about how much backup that patient has in coming and visiting. Then it is time for us to pitch for the idea, because as such it's a costly drug. Secondly, already when the patient reaches us, he's already in a very bad state. Visual
Yes.
outcome is poor. So what we can provide to the patient, what I say is at least he should be able to do all his daily activities without any support.
Okay.
And most of them, I'll tell you, it will be in the ratio of 70 to 30. 30% I put on PRN, and 70% if the patient has a support of any panel, or if he's in a TPA or something of that sort, then it becomes easier for us to put the patient on treatment. Example, for my that first patient who was a kidney failure patient, he's very compliant. He comes and he takes the injections. He's after the third loading dose, basically I feel I have given him 5 loading doses. So after third loading dose, he had a rebound of the SRF. And then again, he made a hue and cry how it can happen, this, that we are giving the best injection. That is how it was pitched to him. So again, to manage the things, it becomes difficult if the patient doesn't have the monetary support. So what I feel is, if the patient is not able to come to you for the treat and extend without any monetary support, I feel put him on the PRN basis. At least he'll come every month. Because in treat and extend, whenever he comes, he has to get injected.
Yes, sir.
Point in him coming. And if he loses that follow-up, then again that disease progression will again increase. And then again you have to go back to the loading doses and again start everything.
70/30 is a great ratio actually.
Yeah.
And so another question is, sir, that on treat and extend, what maximum duration you have achieved between two injections, Q12, Q16, if we talk about?
I've gone to, I feel, Q8 for one of my patient. He's still, today only had come for a follow-up. He's doing very well.
Okay.
From a M panel category. So he can go on, come and take it. So at 2 years, I feel he's maintaining that at the 8-week interval.
And sir, regarding the fluid, you said that there was a rebound of SRF. So another question which keeps on arising is the role of IRF and SRF. So as you all know that IRF is considered the more detrimental fluid. And I have also talked to several QLs. They have said that a little bit of residual SRF, if there is no impact on visual acuity or durability, then that a little bit of SRF can be tolerated. So, do you all follow the same concept, or you just switch the drug and go after that little bit of SRF which is left?
No, what I do is I basically correlate the visual acuity. That is
Yes.
very important. So that is my finding factor more than SRF. Little bit of SRF, I can leave it. I tell the patient, you come again, we'll see how it is. And if it required, I'll inject again. That's what I do.
And so, do you think you might be aware of the revised price of IVIA?
Yes.
So, do you think it will create a little bit of impact regarding the adherence or acceptability in the
Definitely.
patient?
So it gives a cushion for me to explain to the patient between Razumab and Eccentrics, because it falls in that category.
Yes, sir.
They can also have, I can tell them that in Eccentrics, you have to give much more injections. In here, I can tell at least in 2 years, you'll be getting around 10 to 12. I can
Yes.
confidently tell that if a patient of ILIA is there. And previously, I feel you had a this in which you were giving some free doses also.
Yes, sir. So initially it was 1+1. First injection, second injection is free. Then it was 1+2 throughout.
So I
But
feel it is closed now. But so this it's a very competitive positioning you have placed. So I feel
yes,
it's really going to help the patients, especially
yes,
in DME also. It gives very good results. I've got very good results with ILIA with DME. But here it was
yes.
DME, so I didn't put those slides.
Okay, sir. Thank you very much. Anyone else from the audience, if you have any question for Dr. Vinay? I think, sir, it was a very lucid presentation and no one has any doubts, so it's good. Ma'am, a question for you, ma'am, whether you have used faricimab in your practice?
Yes, I have used faricimab in my practice, and I have seen that after one injection, usually the patient doesn't respond fully. I have to give at least three loading. After that, only I start seeing the results. And I don't have any long-term data, frankly, because recently only I have started using. No doubt the hard exudate reduction impact is there that I have seen. But Eylea is working well, Abhi, in my patients.
Yes,
So,
ma'am.
Abhi, I'm like, Abhi, faricimab results I'm going to see on long term. Like short term, I would say ki it takes time to drive the macula.
Okay, ma'am. So this is what we have been hearing throughout that, 3 or 4 injections at least here in
At
Delhi
least,
also,
yeah.
or Jaipur also. In AIOC, there are also a few talks. They said that it takes a little bit time, and hard exudate part also, what you are saying, that we have heard also that it leads to resolution of hard exudates
Yes.
in a bit better way as compared to this other drugs which are available.
Yes.
Ma'am, so what is your take on this Ang2 versus VEGF debate? So whether you think that the hard exudate resolution, it is because of the Ang2 effect, or something else which is related to the drug?
Seriously, I really don't know what is causing that hard exit reduction. But if the studies which I have already presented so much, in which they are saying that it doesn't have any additional benefit, I don't know then why, like what is the factor that is contributing to that reduction? Because see, frankly, here the faricimab, I would like to keep it compared to the Ozurdex. Because see, in the chronic edemas, in the hard exudate migration part and all, actually we compare more with the Ozurdex. I don't know why everyone is discussing between other anti-VEGFs. So abhi to filhal, I think that I would rather compare the results because of Ozurdex versus faricimab. Versus faricimab is still fine. Matlab, this is what I would like in the like coming meeting. Somebody should discuss the comparison between these two.
So, okay. So, ma'am, regarding these two things, so as to what I was told when I was discussing with few of the girls, because they have used a lot of this faricimab also.
Hmm.
That firstly, as to ma'am, it is available in the public domain. Even the US FDA, which has approved the drug, they have criticized, that there is no clinical benefit of the additional Ang2. Another thing, which when we question the same thing, that if you are saying that the drug is giving good effects, in resolution of this hard exudates, or vessel stabilization, what could be the potential factor? So what we were told is that, ma'am, this and the faricimab, the other arm of the faricimab, it is basically ranibizumab. It is almost similar to that of ranibizumab, and that has been mentioned again in the US FDA commentary. And since it is much higher to that what we use in ranibizumab, 0.5 mg, it is almost 6 mg. So that could be one of the driving factors behind improved results of faricimab. But still, the jury is still out that what's causing it. Maybe we can be in touch, and over the year we can get to know that whether it is leading to the increased durability or not.
But the drying effect of Eylea is still better, I would
Yes,
say.
ma'am. So drying. So if we are asked, then I'll not be biased. Still, brolucizumab has the best drying effect.
No
So
doubt in that, if I compare to the brolucizumab.
so that we all know that brolucizumab was one of the drug that if the adverse events were not associated, it would have blown the market. So that's a fact. But again, I would reiterate the factors which are because I know few of the doctors who used to say that touchwood इतना अच्छा ड्रग है मेरे को कोई रिएक्शन नहीं आया एंड उनके इधर आते हुए वी हैव नोटिस्ड इट एंड so in CFS, Dr. Dinesh Talwar and Dr. Lalit, they gave this data that हमने 700 या 800 इंजेक्शन लगाए उसमें एक बंदा PL नेगेटिव हुआ. If you are ready to live with that ratio or stats, then you can use. So that factor only has limited the growth of brolucizumab, but at least otherwise it was a very good molecule, at least this drying wise.
Yes.
So, ma'am, if anyone has questions with ma'am regarding the second slide, Dr. Vinay, maybe you have some.
I actually have got no experience with faricimab. I have not given any
Okay.
injection.
Okay, sir.
comment. But Eylea, if I compare, it has got very good, as madam has told, in drying it. I have got very good results with DME patients also. So but only thing was the cost factor, and I feel now even we have taken down the cost factor now, so it will really help us to push that thing into DME also more.
Yes, sir. So we got this input from a lot of tier 2 cities, doctors that Delhi में तो फिर भी चल जाता है, but वहाँ पे upfront cost is a big issue, 55-60,000. Whether we are giving 1+1 or 1+2, that comes afterwards. पहले patient को वो एक injection का पैसा देना पड़ता है.
Yes.
So that was a input which we received throughout, and based upon that, we tried to balance the price. And also, we are coming with the 8 mg very soon. Mostly, we'll get the approval next month, and I think it will hit the market anywhere between September or October. So with 8 mg, we will again be coming with this PAP program 1+1, so and 1+2, whatever it will be decided at that time.
So I've
Yes.
already given 8 mg aflibercept. One of my patient from foreign,
Yes,
she
ma'am.
came with the injection in her hand just to take that injection. And I like that even vial also, it was a preloaded vial. It was very easy to give. There cannot be any mistake in the amount of the drug being injected also.
Because of PFS, ma'am.
PFS, 8
Okay.
mg aflibercept. It
So
was
in
good.
India, I don't think so. We'll be coming with PFS. It will be the same old
Vial,
vials.
vial one only, okay.
Yes, ma'am. Because we cannot talk this here. Maybe in person we'll talk someday that why vial, why not PFS. There are reasons behind it. But we will be coming very soon. Because it's in the US and Europe from past 2.5 years, so we are hearing a lot of good things about 8 mg, particularly regarding durability.
Yes.
In fact, in Europe, Eylea HD is the only drug which has gone approval for 6 monthly regimens. That means almost Q24. It 2 injections in a year for a patient. So that's a great news if same can be replicated here in India also. So
Yes.
just fingers crossed, ma'am. We are waiting for the drug.
Okay, fine.
Okay, so if we don't have any queries, then I'd like to thank both the speakers and all the doctors who have joined in to listen the talk. And thank you again, and have
Thank
a
you
good
so
night.
much for giving me this opportunity. Thanks.
Thanks, ma'am. It was a pleasure, ma'am.
Okay.
Right.
Thank you, sir.
Thank you.
Bye, all.